and thank you for having me here. It's an absolute pleasure to be here in Switzerland, and it's a great opportunity for me to learn more about your unique health service as well. And I do apologise that I can't speak to you in French or German, despite having studied French for quite a while at school. It is not up to scratch, so sorry for that. But yes, I think you're exactly right. What brought me to learning health systems is basically a disappointment, really, with the evidence base. When I started studying medicine at first, I was very idealistic, and I thought all the evidence is there, and we will do healthcare by applying the evidence to the patients that we meet every day. And I thought that this would be a simple matter of looking up the randomized controlled trials, which obviously will have been done, and then applying that to the patients in front of me. And that was very much encouraged as I went through medical school. No decision should be made without referring to the evidence base. But I found then that when I graduated from medicine and started to work as a junior doctor, that what I found on the ground was something very different. I found that my seniors were treating similar patients in very different ways. And I assumed to begin with that probably what was going on is that they were lazy, or that they hadn't read the trials, or they weren't following the guidelines, and that they were just maybe bad doctors. And then as I became a little bit more senior myself, as I specialized in psychiatry and then in child and adolescent psychiatry, I started myself going to the evidence base to look to see how I should be treating the patients in my care, and was very disappointed to find that actually the evidence often doesn't exist, and there are huge gaps in that evidence base. And I think the penny finally dropped for me one afternoon as I sat in a lecture on anxiety disorders, and a very eminent professor in that area was going through one by one each of the anxiety disorders and trying to explain to us the treatment for each. And basically it went something like, yes, well, we don't quite understand which drug is better or which therapy is superior for this particular condition, but this is how I treat my patients, but my colleagues in a different unit treat them in a different way completely, and we're not really sure. And at that point, I started thinking back to my earlier degree in software engineering, and started to think that, well, we're gathering all this evidence in electronic health records, so why can't we use that to fill the gaps in the evidence base? And that's really what led me to looking at learning health systems. And when I got into it, I realized that there was a really interesting field of research here. So I'm going to tell you a little bit about that today. So, I mean, what is a learning health system? Ultimately, at the highest level, it's a system that attempts at least to learn from every patient who's treated. The Institute of Medicine in the US, which is commonly agreed to have coined the term, has a slightly more nuanced definition, as you can see here. Generally, when we talk about learning health systems, we're talking about systems that rely on routine data that is collected about patients, and therefore informatics is very important in that process, and giving us the ability to bring all that data together. But equally important are, as it says here, the incentives, the culture, the continuous improvement, quality improvement. These other aspects of learning health systems are as critical as the informatics. And in fact, it's really a socio-technical challenge rather than just a technical challenge, and I'll come back to that throughout this presentation. Chuck Friedman, who I believe visited Switzerland recently to talk about learning health systems, and is generally regarded as, I suppose, the grandfather of learning health systems, and based in Michigan in the US, has come up with this very simple but powerful diagram that really explains what a learning health system is. And what this means really is that you start at the bottom with a problem in healthcare, a challenge, a patient who needs to be treated, or a group of patients, or a management decision that has to be made. You assemble the data, you analyze the data, you interpret it, come to some insight from that analysis, and that, I suppose, is the informatics part of the cycle, and that's the blue side of the cycle. But then just as importantly, you have to feed that insight back into the system and hopefully bring about some sort of change. And that change could be a change in research and findings that you come up with. It could be change to a system at a national level, the sort of things that we've been talking about today. It could be at a regional level, in terms of understanding the needs of local populations and prioritising care. Or it could be at a very local level within a provider or even for an individual clinician. And so you've got the blue side and the red side of the cycle, and they're both equally important. So traditionally, we would gather the information, we'd gather the data, and we would come to some insight, and our way of getting it back into the system to produce a change was to write an article and publish it in a traditional journal. Now, it might take us a couple of years to do the research, maybe months or years to write it up, and then just as long again sometimes to get it published. And then somebody might read that article, or they might not. It might be incorporated into some guidelines, or it might not. And eventually, somebody might actually change the way they treat a patient based on the article that has been written. But that process can take many years, as I'm sure we all know. So the idea with a learning health system is to look at alternative ways of feeding those insights back into the system, bringing about a change more quickly. And to do that is not really a technical challenge, but it's more of a sociological challenge. We need to understand behavior change theory. We need to understand sociological approaches, complexity theory. We need to understand the unintended consequences of feeding decisions back, or feeding insights back into a system, and how that will play out in practice. And again, it comes back to this red side of the cycle. Okay, so a couple of years ago, I traveled around the world where I could find people who were working on learning health systems, and I tried to find certain categories of learning health systems, the sort of things that people were implementing locally. And these are the main types that I found in practice. You know, so there were many people doing comparative effectiveness research, which I'll talk about. There were surveillance systems emerging. There was a lot of benchmarking work going on. And there were clearly decision support systems being used and predictive analytics being developed. And I think since then, these have increased even further in their use. They're not mutually exclusive. There are many overlaps between these, as I'm sure you'll understand. But I'll go through these particular types and say a little bit about each of them. So comparative effectiveness research really brings me back to the story that I started with, that issue of the lecture where the professor is telling us about the anxiety disorders and that he doesn't actually know which treatments are most effective. And we might not know that because the randomized control trial for a particular drug hasn't been done. Or it might be that the patient that I have in front of me is completely different than the type of patient who met the inclusion criteria for the particular study. But if we think that we're using mostly electronic records in mental health care in the UK, so I'm seeing hundreds of patients every year. I'm recording their demographic details. I'm recording the symptoms that they present with. I'm also recording the diagnosis that they receive and any investigations, and then recording what treatment I give to that particular patient, and sometimes I record whether or not it worked. So you think, if we've got all that data, why can't we go back retrospectively and say, okay, we've got a new group of patients that we're interested in, a particular demographic, and we want to know, with a particular diagnosis, and we want to know what is the optimal treatment for that patient. Why can't we go back retrospectively, create a cohort of patients who have similar demographics to the patients that we're interested in, who have the same diagnosis, and then look at all the different ways in which they've been treated and compare the outcomes of those treatments. And this is effectively a retrospective observational study, a type of comparative effectiveness research. And this is something that is increasingly being used around the world. I visited Optum Labs, which is a not-for-profit subsidiary of a large insurance company in the US, and they had access to well over 100 million patients' claims data, and also 40 million patients' electronic records, rich data, and they were performing these retrospective observational studies, and they were feeling that they could do it as an alternative in many cases to randomized controlled trials. The advantages are obviously that it's much cheaper. So I met Paul Wallace, who was running Optum Labs there, and he told me that you could do perhaps 100 of these observational studies for the price of one RCT. They're also quick because you don't need to recruit patients and record the data. And they're based on real patients, so they're not based on the type of patients who have no comorbidities and meet the strict inclusion criteria. These are based on patients like the patients I might want to treat. And there's less harm to the patients because you're not exposing patients to new experimental interventions. And I talk about Optum Labs not because it's unique, but because of this quote that I got from Paul Wallace when I was there. And he talked about how he saw research as moving from a hunter-gatherer mode, where we put a lot of effort into collecting data in randomized controlled trials, to a harvest mode where we have the data there and we use it for particular purposes. Obviously, there are huge methodological challenges to doing these observational studies, not least that it's very difficult to say where the cause and effect lies, and difficult or impossible in some cases to control the confounding factors, because these are real patients who've been treated in the past with messy data and so on. But in many cases, we're looking at developing hybrid trials. So in some cases, large observational studies have been done and then supported by a much smaller randomized control trial in order to be more efficient about it. And in some cases, traditional randomized control trials have been supported by these systems. So for example, pragmatic randomized control trials where patients are recruited at the point of care and where data is gathered about them through the electronic record systems that are operating at the point of care. And in some cases, these systems can simply be used to identify potential patients who could be recruited to randomized control trials of the traditional form. So they're very much complementary, and there isn't one size that fits all. Okay, so the next type that I came across was surveillance systems, not as sinister as they might sound initially, but essentially systems that can use routinely collected data to identify epidemiological phenomena or adverse events that are occurring within a population and can track the spread of them. And this is just an example of a global surveillance system that I think was set up by the CDC to track outbreaks of dengue fever. Two particularly interesting case studies that I found was the Food and Drug Administration have set up something called the Mini Sentinel Project. And essentially that has many partners based in providers throughout the US. I think they have access to 150 or 180 million patient records. But rather than all that data being submitted to a central database, a central coordinating center develops queries, and they are then sent out to each of the locations. Each of the locations then receives the query, approves it, gathers the data locally, aggregates it up to a level that can't be identified, and then submits it back to the central coordinating center. And this system is used to identify adverse reactions that are associated with particular new medications or new drug devices. And they can pick up things that wouldn't ordinarily be detected through passive surveillance systems, such as reporting cards from physicians. The second one is Q surveillance, and it's evidence that these systems are not new. It no longer exists, in fact, but it was used in 2009 during the flu pandemic in the UK, and it took the largest vendor for family doctor electronic record systems, had 3,000 practices, and they recorded every time a general practitioner or family doctor recorded things like flu-like symptoms or prescribed antivirals and reported those back to the central public health organization. And in that way, they were able to track the spread of the flu pandemic almost in real time. Okay, so positive deviance is the next type of learning health system that I've come across. Essentially what we're talking about here is benchmarking. And the images that you see in front of you are from an atlas of variation that's developed from some data from my organization within the NHS. But essentially, with positive deviance, you benchmark different individuals, teams, providers, or regions, or even entire health systems. You benchmark them with their peers. You identify the high performers. You then do some research to understand why they're performing highly, and then you disseminate that knowledge to the rest of the peer group in the hope that they can improve to that level. And to make that work, there are these 4 criteria that need to be in place. So you need to have valid performance measures, obviously, to know who is the positive deviant. You also need natural variation, so if everyone's performing exactly the same, it doesn't work. You need openness in the community to talk about your performance as a provider, and you also need an engaged community who are going to do something with the findings once you've created them. And we often find that this is actually the case within healthcare in a way that it might not be within other industries. Okay, so the next type of learning health system that I've come across, clinical decision support systems, which I'm sure many people are aware of. Essentially, these are systems that take either routinely collected data about cohorts of patients or clinical guidelines and use them to support clinicians in making decisions about the care that a patient is going to undergo. And usually they're helpful in particularly complex decisions where there might be many data points that one clinician would struggle to take into account. And I just mentioned these 2 examples here briefly. OpenClinical.net is a UK-based charitable initiative that has developed a machine-readable language called Proforma, which can be used to encode guidelines, clinical guidelines, or care pathways in a way that then can be used to feed clinical decision support systems that can be embedded within systems at the point of care. Transform is another interesting project. It's a pan-European project in 20 collaborating institutions across 10 European countries. And they sought to embed clinical decision support systems within family doctor vendor systems so that the clinicians could use these for diagnostic purposes to aid diagnosis, particularly of abdominal pain presentations. And that was particularly useful because the research from that showed that these systems could be used without slowing down the doctors or resulting in excessive amounts of investigation. And it's worth saying that the evidence base on clinical decision support systems in the past has been mixed, and it hasn't been clear that they actually do save time, save money, or improve care. So that, as with many of these areas, the jury is still out. Okay, so predictive analytics is the next type of learning health system that we've come across. And essentially, with predictive analytics, you want to build a model. You take some routine data about patients, and you identify the variables within that data that are predictive of a particular outcome, usually an outcome that is of high risk or is of high cost. And then you will stratify the population of patients according to the risk of that outcome occurring and try and put in place some sort of mitigation to prevent that from happening. And then you can use a second level of predictive modeling, sometimes called impactability modeling, to tell which of those patients will be most amenable to particular interventions. Okay, and a couple of interesting examples of predictive analytics. I visited Geisinger Health System, which is a large integrated provider in Pennsylvania. And they have a team of engineers who respond to clinical requests to build predictive models. And they have done all sorts of examples, from very simple things such as stratifying patients according to the risk of not turning up for appointments, so that then they can put in interventions that reduces the do not attends, which saves them a lot of money, right through to complex predictive analytics around flow through the hospital, demand for certain services that allows them to adjust where they put the resources on any particular day. Another interesting example was in Japan. I met with the Japanese mega bank, and they have taken a region within Japan and sequenced the genomes of thousands of patients and combined that with phenotypical data, and I think they're working on integrating electronic record data with that. And the idea is that they'll be able to build a predictive model which can show for those patients the likelihood of them developing particular conditions in the future. But interestingly, it will also show them the effect that making lifestyle changes will have on those risks. So a really interesting way of making predictive analytics really relevant to the individual patient. I should say, actually, with predictive analytics, we need to be careful because effectively predictive models are forms of screening, and we should be aware that there will, of course, be false positives and false negatives, and we need to be aware of that when we're testing these and putting them in place, or we could have unintended consequences. Okay, so all of these types of learning health systems that I've covered very briefly, all of them are in use in different places around the world, but none of them are all in use in one particular place, and no particular place has all of these systems together, and I should say none of the systems are ubiquitous everywhere. And the reason for that really is because to produce these systems currently requires an awful lot of infrastructure to support them. You need to take data from within the healthcare system, usually electronic health records. If you want to bridge this across several providers, you need to have those systems be interoperable so that the data can be shared and make sense from one provider to another. You need to decide how you're going to store the data. Do you keep it centrally, where everyone submits their data to a central repository and then loses control of it? Or do you have it regionally, where every provider keeps control of their own data, but then you need a very complex system to bring it all together? You need then perhaps data from outside healthcare. So increasingly we hear about projects that use data from wearables, from social media, from other areas of our lives where data sets are becoming available. We need to think about how they can be included. And then we need an ethical framework for all of this to take place, and one that will give us trust from the public. And without that, as we've seen in the UK, systems can be scrapped and delayed for that very reason. And then I suppose the one that I wanted to focus a little bit on at the bottom here is outcomes. And this is fundamental to all of this. When we treat patients, if we don't record whether a treatment works, then we can't really use any of this data with outcomes. And it sounds obvious, and if you're not a clinician, you would probably imagine that clinicians would actually record whether or not their treatments had worked. But in practice, it doesn't always happen. Sometimes that's because the patient is treated, recovers, doesn't come back. But often it's simply because we record it in such a qualitative or subjective way that it can't be aggregated. So as a psychiatrist, a patient may come to me. They may say, they may be depressed. I may prescribe them an antidepressant. They may come back a month later and tell me that their mood has improved. And I write that down, mood has improved. And then the next patient comes in and the next patient tells me, oh, it hasn't worked. My mood is worse than it was before, and I record that down. And then 100 patients have come through, and then I think, okay, well, what can I do with that data? And there's no way to aggregate improved a little bit or a little bit worse. But these are the sort of things that we record in clinical practice, unfortunately. So I think outcome measurement is absolutely crucial to this whole picture. And outcome measurement can help us in treating patients initially. So if we record the patient's outcomes, we can then respond to changes in their symptoms. And we can do that at each appointment, as you see on this orange line. But in doing that, we can find that things have been getting worse for a month or two, and the person hasn't come to their next appointment. So what we might want to do is use digital technologies to record the patient's outcomes at a more granular level, more frequently, and then respond by giving appointments based on how the patient is doing in terms of their outcomes. So by doing that, we can have more responsive treatment, we can stop things deteriorating, and we can also often have less appointments. So once we've recorded all of those outcomes, it's very useful for the individual direct care of individual patients, as I say, but also we can take that data and we can aggregate it up, and then we can start to compare different teams, different providers, or different levels within the health service. And really, outcome measurement will power all of the things that I've spoken about earlier. Okay, so as I've said, it's a socio-technical system that we're building, and it's not just a technical challenge. The technology is important, but in order to get these things embedded right across the health system, we need to get the technology right, we need to get the data quality right, because currently, I don't know what it's like in Switzerland, but in the UK, the data quality is not always good enough to support these systems. We need a technical workforce that's able to build these systems, and we have to remember that often they need to be adapted for each use. This idea that there's going to be some sort of artificial intelligence system that is going to do everything and put doctors out of business is not really on the cards. But what we will have is a system that needs to be adapted for each case. Then we have a regulatory issue. So getting access to data, first of all, to test algorithms and train algorithms can be very difficult. And then we need to prove that these things actually work. And we did a study at Newcastle where we interviewed a lot of people working on these systems, and we found a whole range of claims that were being made for systems such as this. But what we found was that actually very few of them were supported by real evidence. So we need to look at new ways of testing and evaluating these systems. And then once we've produced the systems, once they're in practice, then they become medical devices often because they're making decisions about patients' care. So they again need to be regulated in use. With systems like artificial intelligence, that can prove difficult when the algorithms are essentially black boxes, and we can't always tell how an algorithm has come to a particular conclusion, at least not in an easily auditable way. So they're all things that have to be overcome. And then there's the business side of things. So we need to prove that they're cost effective, and this has been a major problem within all of health IT, proving cost effectiveness. Often we don't have economic evaluations or economic appraisals before projects are put in place. And often when we do put them in place, we find that they actually don't save any money, don't make clinicians more productive. And so we need to address that. Incentivizing providers is important. So in some cases, a provider might not get paid if the patient doesn't walk through the door and have an appointment, so they're not interested in tele-healthcare and things like that. These are problems that we have in the UK with our commissioning systems. So that needs to be in place. And then we need to look at the workflows. It's no good putting these new technologies into existing systems and expecting them to make systems work better. They probably won't. We need to reimagine the work that we do around the capabilities that we have. We need to normalize it within the workforce, so the clinicians need to accept these systems and need to understand them, be happy with them, and ultimately public trust will be most important, and without that we won't go very far. Okay, so in terms of the future, how will we get to a point where these systems are in use right across all care settings so that they can have a transformational impact on the way we make decisions about patients and about health systems? Ultimately, I think that will only happen when we have platforms on which these systems can be built. And that means the interoperable networks which can supply data to these algorithms that don't have to be rebuilt every time. They need to be reusable, so we need to have systems in place that we can then just build simple applications on top of. So I'll just finish by talking very briefly about two of these platforms that are under development in England that I'm directly involved in. So this slide, hopefully you won't be able to read, very small. basically, I work in an organisation called NHS Digital, and we basically take all of the data flows that come through the NHS for over 50 million patients, and over the last 20 or 30 years, we've built up what we call data sets or collections or surveys or audits or registries about patients, and we've got over 100 of them now. Huge richness of clinical and managerial data that we collect on the health service. Each line on this diagram around the outside represents one of these data sets, and in the center, each one of those boxes and blobs represent a portal to which they can be submitted to. So we've got over 30 portals into which are submitted over 100 data sets. And then we make that data available to researchers and people involved in decision-making within the healthcare system. So what we want to do is to take all of those ones around the edge, and we want to combine them into one national data architecture that gets rid of all the duplication and makes it easier to use and makes them more standardized. And we want to take all the boxes in the center, those 30 submission portals, and we want to create one national data services platform which can be used to collect the data, but can also be used by researchers who want to access the data within a de-identified environment. So that's underway at the moment, and we're hoping to have this completed by 2020 or 2021. But also at the regional level, there is something underway called the target architecture, which is essentially the idea that each region will have an interoperable care system. So they will have all of the providers, all of the family doctors, all of the social services systems, all will have interoperable data so that they can share data across their systems for direct care of the patients, but also for researchers and for the life sciences. And then that regional architecture will then map up onto the national architecture, hopefully, and create a platform onto which these learning health systems that I've talked about can be built. So it's exciting times from that point of view in England. Okay, so we've talked about these 5 different types of learning health systems with the emphasis that they're socio-technical rather than technical challenges. Talked about some of the potential for them, the challenges, and some examples. So thanks for listening, and I'd be happy to take any questions.